has really become a champion, and we'll be hearing from her later. So I want to go back Mount Kilimanjaro. We want to get from 24 to 12. We have 6 years. We've talked about the causes, intervention package. So how can we have practical evidence to help us go faster? Well, I want to thank you for the talk you did yesterday, Mount Kilimanjaro. We want to get from the of being part of that paper in Lancet, where we looked at maternal, newborn and stillbirths, health transition. And what that shows is, as your mortality comes down, the cause structure changes. You have to do more and you have to do it differently as you progress. So I'd like to highlight from the neonatal specific side, what does that mean? What do we need to do? So this is a paper that's published this year in Neonatology. It's open access. And it takes learning across 200 countries, including historical data from the beginning of the last century. Now, I'm a fake Brit. There's lots of things I don't admire about England, so there's lots of things we can't learn. But this is looking at the UK and the US neonatal mortality rate starting from the year 1900. The target of neonatal mortality rate of 12 was hit in these countries around the 1980s. This was just as we were starting to scale up more intensive care. It was really special care with some support. So we can learn from that, but we actually need to go faster. And there's more in our hands to be able to go faster now. This is where we are. So sub-Saharan Africa is at 27, Tanzania at 24. 6 years. We're running. I can see Dr. Bondala has come ready to run. So we've already passed phase 1, where we do things in primary health care. We should have passed most of the things in phase 2, which is getting to facility birth. We're now at 81%. Tees pointed out that actually the family planning is actually a little bit of an anachronism in Tanzania. There's still scope to do more on the family planning side. And that's critical, because if your total fertility rate is very high, you double your population every 10 years. You have to build twice as many hospitals every 10 years just to keep the same coverage. So this is critical. And we're now in phase 3. So how do we go faster in phase 3? The quality of maternity care, not just coverage, but we have to have special newborn care moving towards intensive care. If we scale up intensive care now, we will have inequalities. If we reach everybody with special newborn care, we will change mortality and we won't be increasing inequalities so much. So I want to show you China. China is the fastest reducing neonatal mortality rate in the world. At the moment, Tanzania is going at 2.1% per year. You need to go at 5.7. China is going at 8.1% per year. So how did they do that? Well, that's a whole other story that we don't have time for in this talk, but there is a number of writings about that in the paper, in neonatology, and also in a recent Lancet commission on China. But they did it by having centralized rollout of building neonatal units and bundles of technology and training people in a very systematic way. There was also some things you wouldn't copy because women were not allowed into the neonatal units, and we don't want to copy that. So if we now look at where the world is, this is 200 countries in the year 2021. So has phase 3, this is what Tees showed us yesterday, is where Tanzania is. So we need to get to phase 4 to meet the Sustainable Development Goal. In this phase, we must improve the quality of our maternity care, and we have to scale up small and sick newborn care. This is critical. And if we look at the people in this group who are going fast, so all of these countries are going in the high 4%, close to 5% per year. They were not doing that 4 years ago. They've changed their speed. So let's look at India. So India has an unenviable #1 for neonatal deaths. They have a very large birth cohort, but they have a very ambitious plan. For their goal for 2030, they want single-digit neonatal mortality rate of 9. But they've put their money behind that. So they started around 2011 with a few demonstration units, which UNICEF helped with. And then the government has taken it. The government, and we had them on a webinar a week ago on the toolkit, are spending almost $1 billion a year now across this. So they scaled up. They still pay the human resources bill for the neonatal nurses on 934 units. They've built units. They've really invested in this, and it's so inspiring. But the thing that is really beautiful in the middle of this is they're collecting data on all these babies. It's now 1.2 million admissions to their special care neonatal units a year, and they have an individual level data set, which we've copied here, and we're happy to share with you. So India is one big country. Here in Africa, we have 46 countries in sub-Saharan Africa. And nearly all of us are facing similar issues. So how do we learn together? We don't want to have every 46 countries doing a different education, different this, different that, because we'll waste time. So the NEST is the Newborn Essential Solutions and Technologies, has an alliance to help us learn faster together, to go faster together. And when Ethiopia starts next year, this will be half of Africa's newborn deaths within the NEST Alliance. So this alliance is really led from within Africa, and we're so privileged to have wonderful leadership from Dr. Bundala and the team here. And so excited to see progress. And the whole point is, how do we get systems change faster that is sustainable for small and sick newborn care? And to do that, we need these components that WHO and UNICEF have set out. We need to look at leadership, investment, infrastructure, human resources, these different parts, and they don't just happen on the newborn ward. So to make them happen, we have to be part of a bigger conversation. So this conversation and this conference is amazing. I'm so inspired to see what you're doing. So I want to just walk through some of these for Tanzania. So leadership. There is no doubt you have leadership here. To see your honorable ex-president, Kikwete, not just turning up for 5 minutes, but sitting here, I mean, that is just, I think it's amazing. To see the commitment of the CMO, Dr. Makawani and the team, this is fantastic. In what NEST is doing to support, we're so excited to announce to you that even between 2021 and 2022, some of those facilities saw a statistically significant drop in mortality between 10 and 28% in just 1 year. So if we're able to work together to take this system, Dr. Bundala and the team, to look at what it would take, what needs to be done across the country for you to go fast enough. So this is modeling in the Live Save tool, which shows that with the scale up of this small and sick newborn care package across 80% of districts, but getting 85% coverage in those districts, you could come next to meeting your SDG targets. You will also need to do things in maternal care, and I think the Safer Birth Fund is here, and also Rose and others worked with the government to do this costing. How much would it cost to put units in 146 districts and 27 regional units? Not surprisingly, the setup costs are driven by infrastructure. You know, I've been doing neonatal care for 30 years across Africa. And normally we take a small room off labor ward, we beg for something, we have real problems in what we do, but we need to build better. And I salute Tanzania for really the leadership role they're playing in taking this forward. In fact, the devices are surprisingly affordable. They're not the biggest cost. So this is an affordable cost, especially given the return on investment. So even just taking deaths averted For every $1 in, Tanzania could recoup between 8 and 12 back. So it's not just charity, it's also return on investment. The infrastructure, it will not be effective if for 146 sites, or you will be going on to more sites after that, you have a new architect, a new plan, a new whatever, make the same mistakes. So it's fantastic that you have a standard floor plan. It can, of course, be adapted, but it will be more efficient. And I would like to tell you that, in fact, your floor plan in Tanzania is being adapted in Uganda, so other people are learning. If we look at the devices and supplies, often we don't plan this well. We accept that charity devices, they break. They end up in an equipment graveyard. When we're neonatal doctors or nurses, we love machines that go ping. We need at least 15 per each baby that is sick. But we also need to learn to love our biomedical technicians. And Nahia is going to talk more to us about how we do this in a systems way in Tanzania. But devices don't work on their own. They need human resources. So on the investment case for Tanzania, there's a shortfall of around 2,500 nurses if you were going to meet WHO norms. Even if you go halfway to WHO norms, it's going to be about 1,800. So it's essential to have started even last year to train neonatal nurses and to have that competency-based with skills labs so they know how to use devices. Data is fundamental. We can have the space, the devices, the people, but if we're not measuring, we will be driving blind. And this is an example from Malawi. 27 districts, they now have 37 newborn care units. But when you go to them, they're very variable for their service readiness. And you can read this paper online to see, how many of them have infrastructure, nurse ratios, and so on. But actually, what's driving change is being able to measure coverage. How many babies who are admitted get KMC? How many get CPAP? How many are cold? These are all really critical. And very excited to see the effect of data in Tanzania. So, for example, here's a facility where most babies were cold on admission, and with quality improvement, Dr. Robert Tillier and the team are involved with this with the government. This has really changed, and actually their babies are cold from within the facility. What about infections? So as we work on newborn wards, especially with suboptimal numbers of nurses and devices and space, we're often causing infection outbreaks. And this is actually from a facility in Tanzania showing 90 babies dying within 2 months from a hospital-acquired infection outbreak from gram-negatives that wasn't detected. So we need to do much better with this. I want to conclude by saying change is possible. I've worked for quite a number of years with the Temeke facility, and I cried with happiness the last time I went. This is the nurses and the doctors celebrating when they got a new unit. The new unit is not just good for babies, not just good for women, much more respectful to have showers and places to breastfeed. It's also great for workers, because it's hard for workers. So I want to end with this. How will we get from 24 to 12? We are getting coverage. We need quality. We need to go faster. And to do that, we need to learn across and beyond. Please do join us and share your learnings. Use learnings from this toolkit. And together, not poli-poli, haraka. There's so much we can do to go faster. Will we deliver? Asante.
Thank you so much, Joy. If I can recall anything, haraka, 2 times fast. And we actually have a person who is making us, I think, probably 4 times faster. And this is no other than the Assistant Director for Newborn and Child Health at the Ministry of Health. If you look at him, you might think he's a pediatrician, a neonatologist, an obstetrician, but actually it's none of that. He has his interest in health system strengthening. And if I was to mention 5 people who have done a lot in newborn care in Tanzania, Dr. Bundala names would appear. Dr. Bundala, you are welcome to the podium. That is called KFC for those who don't know, and that is Kangaroo Father Care. Karibu.
Thank you so much, Dr. Martha. And I feel very much honored presenting after Professor Joy, the guru of neonates globally, but also before you, the very key stakeholders in newborn care in this special day where we are commemorating the premature day in the world. Joy have just mentioned a lot of things globally, but just to use a small reference before I start going locally, is that it is estimated every year around 130 to 140 millions are newborns, and among them 2.5 million dies, and 98% of these deaths are coming from low and middle income countries. And in fact, 75% are coming from the Sub-Sahara and South Asia. Tanzania, we're estimating around 2.3 million deliveries every year, and of them 2.2 million are live-born. And among that, we estimate 20%, which is around 250, will need admissions, special care. And we see of all live birth, 15% are likely to be the low birth weight, and of them, again, being the premature. I will be talking as I go forward to see this burden, but the most thing I would be presenting in my presentations is understanding our situations, the action needed, what is happening, and what we should be doing. This presentation, this slide, it just shows the journey of almost 23 years from 1999 to 2022, almost 23 years, but like a reduction of 40% deaths in 23 years, from 40 per 1,000 live births to 24 in 2022. Professor Joy have mentioned very well that in next 6 years, we need to reduce by 50%. We have no time to wait for 20 years. Is it possible? Yes, it is possible, but if we make sure that the newborns, the special care for the essential newborn care and the special care for every newborns is well available, and not under the mango tree, but within the functioning neonatal care unit. And what do we mean by having the neonatal care units? Basically, it's about the premises, having the places where we can take care of those who are critically ill, the stable premature, the stable non-premature, But again, having the adequate equipment, medical supplies, and medicines. It also takes the availability of health workforce, but not only in numbers, but the quality and the competencies they have within the NICU. The guidelines, the standard operating procedures is critical, but also the way we are documenting these newborns who are being admitted and those who are dying for us to make decisions. In Tanzania context, what we defined in our national guidelines, when we are talking about the neonatal care units, basically it is talking not less of the 3 functioning units. I have just mentioned that we need to make sure that we take care of the critical ill, but when they get stable, if they are premature, we need to have the kangaroo mother care wards, general neonatal wards for those who are stable but normal weight. But those who can infect others, we need to have somewhere to isolate them. I want to congratulate all of you who are here, the tremendous efforts we have committed for the past 3 years. In 2018, when we were asking the regions to report of how many hospitals had the neonatal care units, it is only 14 hospitals was able to report. It's good now now as we are celebrating this day, when we asked the same questions in last September, a total of 180 hospitals reported that they have established the neonatal care units. And among them, we had like 102 the council hospitals, 21 was the regional referral hospitals, but the rest was the faith-based organization and the private ones. Going deep now and see what is happening. Yes, we have established the neonatal care units, but we wanted also to know, we are recommending the 4 units in every hospital. How many have all the 4 units? That number is telling us that in the regional referral hospitals, it's only 10 out of 28 have all the 4. And how many have at least 3? That's the intensive care unit, the kangaroo mother care, and the general ward. Okay, we found at least 18 out of 28. And at least 2, we have 21 out of 28. So basically, as we were mentioning, the establishment of neonatal care units, it's not that all facilities have established all these units. And the way forward, as we are going from here, is making sure all the functioning units are available. From the 25 hospitals, which are the district hospitals here, you can see that the numbers goes down. If you wanted to see how many have all the 4 units, 3 out of 25, at least 3, 5, at least 2, 11. So we still need to fight or to make sure that we have these units. Our Joy have just mentioned, I was very much happy hearing that our national floor plan for the NICU, which took us more than 3 years to finalize, that it have already been adopted by our neighbors, Uganda. So we need also to go very much fast to make sure that we are not the only developer of our floor plans, and implementers are coming from other countries. So we have to make sure that we are implementing that. Within that standard, what was agreed in terms of the size, but also to cater for the required bed capacity. For the district hospitals, what we agreed, you can see by counting the intensive care unit, the 4 units, you need at least the 710 square meter without considering the corridors and the other supporting structures like the breast milk, the council room, and the staff rooms. But when we went through looking at the 25 hospitals we have just analyzed, basically there is a range. The range in terms of size from 0 to 134. That's in terms of the size. A message that we have these units, but basically they are that much small. The median, 31, not very far from the mean. To the right side, you can also see, even within the regional hospitals, the sizes are not big to meet the required standard. How many beds? In a hospital with an average of 300 live beds, we're estimating a 42-bed requirements. And this is from the principle that we understand 20% of deliveries will need to be admitted. So if we have like 300, the 20% is the sixth bed capacity is the sixth. This is the sixth small and the sixth newborn which will need to be admitted. The average of 10 days, 10 days hospital stay. If we divide the 6 and 3, you find like you need at least 20. But you have to consider another 20 coming outside, so it's around the 40 bed capacity. So you can see we still have the few beds. So we have the small size, we have the few beds, and what's the implication? Number one, we are not admitting all of those who are needed to be admitted. And even those few we are admitting, most of them we are discharging them prematurely because you cannot stay with one baby for 10 days or more because the space and beds are few. But again, you will understand, we want now to promote the no or the zero separation, the baby and the mother. How can you put within the same room a mother and a baby? Why this? The space that much time. So that's why we need basically to make sure that every health facilities have the neonatal care unit, but again, we need to expand the existing and build the new structures. The structures alone, the premises alone, without the human workforce, we won't attain the quality we want. Thank you for the six governments. In just 2 years, employment over 20,000 service providers. I thought it would be clapping. But also this is a plan in the next 3 years, providing a sponsorship for long courses to over 600 care workers. And of course, among that, the 50% is within the first priorities cadre in the RMCH. But from what we have been looking, what we have been observing from the Zoom meeting, over 80% of the deaths have the correlation with the competence of our providers in the facilities. But again, looking to the different studies, it have seen if you train someone today and you leave without follow-up, 4 to 6 weeks later, the knowledge of the skills drops to 78%. You leave it to 4 to 6 months, it drops to 55%. And the preliminary findings from the safe birth band shows if you train someone, you make a regular follow-up, the skills are likely to be retained for over around 80% after a year. So the approach we are going to go with is to make sure that we establish the hub within the hospitals, within the regions, for the people who will have the selected competencies, will be training others at the skills learning corner, but also they have the capacity to train others at the lower levels depending on the availability of resources. So ladies and gentlemen, we have already packed the equipment. We have now what is called the basic NICU pack, the advanced NICU pack of this number. It's just a call to my colleagues to start now making that. We budget for that, we order for that, we make sure that is appropriate use, but also without forgetting the maintenance of this equipment. The guidelines are there, but we need to make sure that the admissions and documentations is being appropriately done. The very last slide is just to remind all of us a call, the high political commitment from Her Excellency President that from now onward, all hospitals need to establish the functioning neonatal care units. And when we are saying this, it's not only the government facilities, it is including the faith-based organization facilities, the private facilities, to have these neonatal care units. Ladies and gentlemen, this is my own beautiful daughter who was born premature, and at 2 years he was telling, Dad, give me 5. Thank you so much, and thank you for listening.
Now we know when you see a director in sneakers and a t-shirt, there is a driving force at home. He didn't mention the wife is also a pediatrician, and that is why. Yeah. In Swahili, there is a famous saying, ukiona vielea vimeundwa. I don't have a direct translation of English to it, but whenever you see something that is being done that is really nice, there is a driving force behind it. And it's my honor and pleasure to introduce Dr. Nahia Salim Masood, who is the pediatrician, a senior lecturer at MUAS, and director of research and publication at Muhimbili University. She is my teacher, she is a researcher, and she's also a clinical lead at NEST. So she's going to tell us what can we do to run the 2.5 marathon that has been shared. Dr. Nahia, welcome to the podium.
Good morning, everyone. I'm just checking my baby. She's still breathing. So I'll just try to summarize very quickly because of time. Most of the things have been touch-based. I'll just focus on where the message is not very clear and where I need to emphasize. So again, Nahia Salim from MUHAS, and I'll be presenting to you how are we going to be fast enough to sustain, to implement and sustain what we are scaling, but this is tailored towards neonatal intensive care and basic innovations and solutions towards quality small and sick newborn care. So if you look at this title, first of all, there are keywords: neonatal innovations and solutions. There are existing technologies, there are also coming technologies in a pipeline under R&D. All these are possibilities for us to use effectively to make impact. Sorry, I don't know what I did with technologies. Just wanted to embarrass me. Okay, sorry again. So just to save time, this is my outline. I'll take you through in a nutshell again what NEST is and how are we implementing, embedding the message to Professor Joy, what she presented, what is the right device, and how are we maintaining these right devices, and how are we creating the right ecosystem for the human resource to utilize effectively those innovations. And then I'll take you through the implementation learnings on how we do the scaling, but also how we move forward together. So you have seen this slide. I don't want to repeat. As NEST 360 in Tanzania, we have started setting up facilities since 2019. And this was towards the end of 2019, and then COVID started, but we still persisted and survived and thrived. We continue to set up our facilities, and the first facility was installed in, I remember, December 2020, and then we continue to install in more, in 7 facilities in Tanzania. But overall, this is an alliance. Nest 360 is an alliance which is hosted and taken care by more than 20 organizations. We will be 15 in Africa, moving to phase 2 of starting 2024. And basically, we are supporting African countries to meet the targets. The targets are there, the policies are there, the guidelines are there. Our role is to strengthen the health system in a package which is possible and contextualized in countries for effective implementation to get that target. I remember Dr. Makwani said we have to aim, so that aiming target, how are we aiming to achieve that? It's only 6 years to the target, and we need to move faster than China, I think, Professor Joy. Faster than China. So you just imagine a Chinese working in his field, so we need to mimic that level more than that, because the Chinese have attained that in less than a decade, and we don't have a decade. We only have 6 years, so it should be less than that 6 years, possibly to attain that level. So what we do again, the program itself is not a project, it's a program. It's hosted under Ifakara Health Institute, but we work very closely with the central government, the Minister of Health of mainland, and also the Minister of Health in Zanzibar to implement together. And in this collaboration, we work with Muhimbili University of Health and Allied Science, but also the Dar es Salaam Institute of Technologies, together with our local distributor ANUDHA, to make it possible. And we integrate everything into the system as needed. So just in a nutshell, in phase 1, we were in 3 regions, Dar es Salaam, Mbeya, and Mwanza. And in moving to phase 4, we will add, Dar es Salaam, Mbeya, and Kilimanjaro. Mwanza is stacking, they are very aggressive. So towards phase 2, we will include Mwanza and Zanzibar, but also scaling up in the phase 1 regions. And working with the local government and central government to implement. So how do we work? Learnings from phase 1. If you look at phase 1, you say, why did you just place yourself in 7 facilities? We were creating learning, but also these learnings and these facilities in phase 1 should be effectively used as hubs. And all these were purposely linked to the biomedical engineering institutions, the technology institutions. So if you look at how we placed ourselves, is Dar es Salaam linked to DIT, Kilimanjaro linked to Arusha Tech, but also Mbeya linked with MOST. So this facility needs to be linked with clinical areas so that we sustain and use effectively our technologies, but also we continue innovate through that learnings to customize our needs, but also utilize our technologies effectively as we move forward. So we do work with partner. We call in for stronger and stronger partnership in the regions, and any partner is sitting in this hall today in the region, please, if we are not in touch, let's get in touch. If you are implementing mother and child and newborns, please, let's get in touch to implement together. So we work with professional associations and all stakeholders to make it possible. So this is what we see in the facilities, equipment graveyards. Equipment graveyards, and I'm worried that when we are moving from now, that we have commodities and life-saving technologies assisted by the government. The government is investing a lot in this process. So we have commodities, newborn commodities, including technologies. I'm also worried that we will see this technology in the HDU and NICU not utilized. So instead of helping the babies, we'll be admitting technologies and they'll be sitting there. So we need to create an ecosystem which will work. We need a functional neonatal care unit. So most of these life-saving technologies, you see, they are developed in the developed countries, and most of these are imported or donated to our low resource settings. So what NEST is doing is looking at the technologies which are possible and they are in the market, which are effective enough, affordable enough, and sustainable enough, and suitable for our environment. And these are tailored towards the level of care which we are targeting to make impact. So if you look at these facilities, again, I'm emphasizing they lack this technology, life-saving technology. Even the minimal bundle to save life is not there for small and sick newborn. This is just a picture in Temeke. I think you saw this in one of the slides from Professor Joy. This is on-site mentorship ongoing at Temeke in one of the QI process. So which devices do we need? Which technologies do we need? All these technologies are tailored towards the neonatal signal functions for impact. So you will see technologies, maybe it will be hard for you to see, but all these resources are free online through the NEST 360 website, www.net360.org, and it's downloadable, you can use for free, you can share, and this is the main purpose of sharing learnings and moving fast as needed within Africa and sub-Saharan Africa, including Tanzania. So the band of technology is customized through the signal functions. We have technologies which are supporting hydration, nutrition, and delivery of drugs, but also we have jaundice management, point of care diagnostic test, infection prevention, respiratory support bundle, but also the thermal care management bundle. And what we do is identify the technologies and take it through the target profile, product profile, to make sure that it can be used in our low resource countries and effectively getting inputs from stakeholders for safe use and efficiency of these drugs to be adopted in countries. Just in a nutshell, this is a process. So we do identify, we do the target product profile, we do the technical testing if this equipment can survive in harsh environment, but also environmental testing, subjecting that equipment or device to harsh environment, surge, voltage surges, extreme heat, humidity, looking at our local environment and what is happening truly in our clinical areas. And then we also do usability testing. And this technology, you will see getting a sticker that it is NEST qualified on top of what has been qualified to be in the market. Not replacing other certification bodies, but we do think that this is needed from the learnings we see. Most of these technologies or devices are not actually, did not go through the R&D in the neonatal population. And you see significant deviation sometimes when you do testing. So you will get a value, but the deviation from that value could be not acceptable. So we try our best to saturate the target devices, so the technologies, as much as possible for the healthcare workers to have options when they need, looking at the impact and how that device is functional. Through the TPP, but also we created device specifications and device costing, together with the type of technologies tailored to the level of service of care you are required to deliver. And all these details are hosted currently at the MSD to support the delivery and distribution and sustaining these technologies to be in our health centers, in our district hospitals, to implement what is needed. But also there's a simple tool, I think Alice has presented yesterday afternoon, I don't want to repeat this, and this simple tool for costing will allow you to just plug few numbers and give you the right numbers you expect to start as a bundle, plus the costing, depending on your data at your facility. Why do we talk about people? We need to have the right people and create educational ecosystem. So through NEST 360, we do work with institutions in the pre-service to influence curriculums, both from clinical plus technical institutions, to ensure that the curriculum has the right content tailored towards the small and sick newborn care, but also the right modules to support technology use. So we have free resources, again, job aids, videos, modules for technical and clinical, which are very useful, and you can freely download and learn on how to use these technologies, but also maintain. But also we have created a GIC course, which is more of adult learning to support the in-service training for mentors to support others in trainings, so that they have that skills of delivering the education to their mentees in the facilities. And all these are hands-on, using the competence-based curriculum, which is in place for use. We also have a QI system, which is linked to the data use. So we use effectively the data which we are collecting to support the facilities to make decisions, but also targeting what is the gap in terms of quality process, quality assurance, and quality improvement process. What are they targeting, and how do you target? What's your target achievement in terms of using data, but also planning within the facilities? We are also hosting and advocating for invention education and fostering local innovation capacity. So what is happening in terms of delivery and sustaining? During COVID pandemic, as you heard, we started in the middle of the pandemic. So we had to think of and innovate the best way to support countries. So we saw a need to create an independent NGO, which is called Hatch. And Hatch is actually linking African countries to support them in procurement process, looking at the market, global market, what is existing, which devices are cost effective and available for the country to adopt through their local distributors and purchase in a lower price for them to have those technologies to support newborn care. And the Hatch is actually working through the local distributors. Currently in Tanzania is Anudha, and linked to the MSD to sustain this distribution. Again, you see a local distributor supporting services. This is very critical. Biomedical engineers. How many biomedical engineers are in this room today? A show of hand? None. Even for Nest, where are they? So we have to include and think of biomedical engineers. When you talk of clinicians, professional associations, we need to think of biomedical engineers to sustain and effectively use these technologies. Technologies need preventive maintenance, corrective maintenance, be safe for use for your patient. So all the regional commissioners, RMOs, please, if you don't have a biomedical engineer in your region, call for one and echo for this, so that you sustain your technology and you save lives. So together with this innovation, we saw a huge challenge in terms of utilization of these devices. As I said, you may see a facility complaining that we don't have enough CPAPs. This is why we don't do CPAPs. But we have various CPAPs. When you visit the facility, you see CPAPs with dusty in the corners, not utilized. Why are you not using CPAPs? So we also we came up with these ideas of monitoring the usage of these devices, but also assisting the biomedicals to track and also do the planned corrective maintenance, but also preventive maintenance. So we created a Hadley monitoring device, which is just a plug-on in your device, plugged to your electric source, and it will track if that device is on and off, but also they will move. So just to highlight, sorry, I don't know what I did. Oh, this is so sensitive. Touch device. So these are just new technologies ongoing, evaluated for possible support in the clinical areas. So we have Celsi monitors, but also a Celsi mattress, which can just be plugged in on the cot of the baby, and it will maintain a proper temperature, normothermic state to the baby, and adjusting as needed. But also we are working with VIO CPAP to also see and explore how the VIO CPAP can best be used as we are scaling to district levels and lower levels, but also supporting in terms of referral system. As I said, we also support African-led innovation, invention educations, and we do support biomedical engineers and young scientists to develop their innovations, and especially in supplies and consumables, small tubes which are difficult to get, small supplies which are difficult to get in the market. These innovators can do a lot to ensure that those technologies are continuously used, because the supplies and other consumables supporting that care are there. Because we have seen this already, and we are also calling for the young innovators in our schools and institutions to come forward and innovate this. And we learned a lot from COVID-19. We saw a lot of innovations coming out from our local institutions. So just 1 minute, I can't see the chair. Oh my God, okay. Way forward, way forward. And I see this slide, but the way forward is more than this slide. Always remember this wheel. This is a health system building block. Sorry, I used to see my slides behind. So always a health system building block. So learning from phase 1, we have identified lack of continuum of care. So we are placing ourselves and calling for partnership, and already partnering with all the major 3 impactful innovations in Tanzania, including mMama and Safer Birth Band of Care, to create a continuum of care. So the Safer Birth Band of Care will be placed themselves in the maternity area, including theaters, but also linking to the inpatient care in the facilities for the neonatal care units, but also care of small and sick newborn to ensure that these newborns survive. We are also linking to improve the transportation, intra and inter-facility transportation for these babies, and working with mMama and Touch Foundation, ambulatory care, including the respiratory support of using the VIO CPAP, so that we can safely transport this facility to another. But also creating learnings in Mwanza, working with Touch Foundation on how best to create feasibility study on how best we can improve our postnatal follow-up for these babies to thrive and transform. So here we are calling for more partnership to leverage resources, but also create high impact in our regions. As you can see in this photo, there's a team sitting just on your, I think you to be on your right. This is RMO in Dar es Salaam sitting with within regional office in Dar es Salaam. It was, I think it was, 3rd of November, 2023, just early this month. And Dar es Salaam, I could say, is almost ready. And the beautiful thing is they have RRH already in the phase 1 of NEST. They have all national hospital in place already, and we want to scale to create a hub and spoke model to transform care of small and sick newborn and save more lives. So how do we do this? Is look at the burden. Where is the burden? Which facilities have highest burden? We have to target. We have to aim. Not going coordination within the hubs and spokes. Very important, especially also for human resource. The competence-based mentorship and quality control improvement, quality improvement processes also need to be communicating. So the mentorship should be upward and downward, but also communicating and coordinated within the region for impact, the target tailored towards that region. Asante sana, please welcome for more impact.
Thank you so much, Nahia, for showing us the innovations that we need to do. And now we'll go to the panel. I would wish to welcome our 4 panelists together with the previous speakers to come to the podium so that we can hear what they have to say, but also have an opportunity to ask questions. So the first 3 speakers, if they can take the stage, and then I'll also introduce the 4 panelists. Isn't that beautiful with the KMC position? Clap the hands for them. Thank you so much. So on the stage, I would wish to invite Dr. Topista Jacob. Dr. Topista Jacob is a pediatrician. The beauty of this panel is I'm related to each and every one. So Topista was actually a sister to me. She welcomed me when I joined the MED program at Muimbili. And she was going to represent the professional association. And with her, who's going to join us is Dr. Monica Frey. She's also a friend, a sister. Don't be misled by her color. She speaks a lot of Swahili. She's currently based in Lushoto, Tanga, and she's done quite a lot in Mbeya, including the review of neonatal guideline, and she'll be representing the developing partners. Again, I would like to invite Dr. Furaha Mwakafilwa. He's a district medical officer at Manyoni, DMO. I can say he's actually my student because by the time he graduated, I was already a pediatrician, and he has been mentored by a dear friend, neonatologist at Mbeya. And last but not least, we wish to save the best for the last, is a former premature baby, a champion, Miss Doris Moel, who is going to talk about the champions as far as the prematurity is concerned. Karibuni. Asante, you can take a seat. So if I can ask, I see Topista is already holding her mic. Yes. So what is the role of professional association? We've been told we have to run 2.5 times faster to make it happen. Our mothers are ahead of us. What can professional association do?
So thank you so much, Dr. Martha, and thank you for the panelists. Really, the science that we got and the numbers are immense. So for me, I just want to give a background on the numbers again, as said by Bundala and Professor earlier, that in the last 15 years, we managed to drop from 26 per 1,000 to 24. It means if we go with the same speed, we will need 60 years to be at 12 live births per 1,000. So this is huge, man. 60 years, ina maana tutakuwa sisi wote tulioko hapa tumekufa nadhani. Can you imagine that? Yeah, so yani napata kuogopa when I hear like we need to move fast, haraka haraka yenye baraka. I think ni speed ya light inahitajika so that we can be there. So we learn from the Chinese, and I'll go to the question now. What can the professional association do to contribute in the reduction of neonatal mortality? One thing that comes out is on the competence area, as said by Dr. Bundala and yesterday by Dr. Makwan, is that 86% of the maternal mortality is contributed to the competence of the service providers. And who are the service providers? These are the pediatricians, they are frontline service providers, they are nurses, they are biomedical engineers, they are clinical officers, and everyone who is seeing these newborns who are born, and they somehow fall in a professional association. So the role of the professional association is to make sure that the service providers are competent enough to save life. So we as a professional association, I think we have that capacity, we have that capability. It's just a one phone call away actually from the Ministry of Health. to give us that task. Tunasemaga mchawi mpe mwanao akulele. We are the frontline service providers. We are the professional association who can do that job, and I will ask our colleagues at the ministry to tap into that resource so that we can together help that. Another thing that professional associations can do is advocacy. Professional associations are independent organizations, and so they can engage with the government bodies, policy makers to influence resource allocation, to influence quality of care standards and everything. So I think is an area where we have not done much, but as even now we are advocating for a better quality of services, and we can generate that data and inform what is happening at the ground level. Another area is knowledge sharing and research. We've seen how Nahia has demonstrated what the NEST is doing. And Naya falls under the Pediatric Association of Tanzania. So we are proud of her, and we are motivating other professional associations really to tap into that and take lead in terms of reducing the mortalities and the morbidities that are happening. So we serve as a platform where we can disseminate research results, scale up best practices, and all that that can support the nation into moving faster to reach the goal. Another area is improvement in public health initiatives. The professional association have been able to engage into implementation of activities and best practices. So we have the capability to implement actual activities at facility level. We currently engaged in the MPDCR. I think initially it was only the few associations who were really engaged, but now we have a lot of associations who are engaging into the MPDCR Zoom meetings, and from there we are doing the clinical audit of perinatal mortality, maternal mortality, and even other childhood mortality. So it's an area where we really have the resources and the capability to audit and give out a report and support the health system strengthening. Another area is the monitoring and evaluation of the interventions that are at the ministry level or at the government level. So we'll be able to contribute in terms of data collection, analysis, and providing feedback to the processes where are we doing good and where we are not doing good. Another area is, so the professional association are the ones who have the people who are really on the front line. So what else can we do? As I said, advocacy, but this is a calling now to the Minister of Health. I will say, we have the capability to change the mindset of the frontline service providers. Haingii akilini pale unapomwona mtu wa huduma anapambana kusave life ya mama without understanding huyu mama kwa nini anaingia kwenye hii hustle. This mom wants a baby. This mama is in this hustle because she wants a live baby. Kwa hiyo when you are looking at that mama, ukaona tu nina save life of mama, huyu mama akiwa hai amepoteza mtoto, amepoteza kila kitu. It's not only the baby, has lost her dream, her humanity, dignity and everything into that battle. Na kesho atakuja tena in the same battle. Wewe you're just looking at saving this mama, you are not looking at saving life. Kwa hiyo at that advocacy level tungeomba pia we need to have for the professional associations to be able to really showcase and really show the difference. We need political commitment from top down. Tunaangalia last week tulikuwa tuna mama ambaye bahati mbaya alifariki kwenye uzazi. Waziri amesema anataka ripoti ndani ya siku 7. And yesterday we had 3 U-turn crashed. When is the report going to come out? Today as we speak, I don't know what time is this, how many newborns have died already, na tujui report zao zitatoka lini. Can we elevate the newborn death into that level? Kuwe na mtu anasema mtoto akifa, inakuwa sio kesi ya mtu wa huduma tu, ni kesi kuanzia level ya raisi, kwamba kwa nini huyu mtoto amekufa. What is wrong with the health system strengthening? What is wrong with the care delivery? What is wrong with the service provider? Yani hapo mpaka wote tukipata report, we will be there na hiyo faster itakuwa na meaningful result. Thank you, Martha.
Thank you so much. I think we are moving at a 4 times faster than what Joy has recommended. So I have Dr. Furaha, yeah? The professional association is there. You have the supportive from the ministry. What does the district hospital, the health center, yeah? TAMISEMI people, are you ready for this? What does it take to establish a NICU, neonatal care unit?
As we all agree, we know that majority of sick newborns are seen at the primary health facilities at first, before referral to higher levels. So this was also happening in Manyoni District Hospital, where we have approximately total delivery of 400 deliveries per month. You can imagine the number of sick newborn whom we are getting. And these newborn were cared or were admitted in general pediatric and or in postnatal ward, where there was no limitation of visitors and there were no staff to care for these neonates. So seeing this together with my council health management team and the hospital management team, we decided to initiate a neonatal care unit. So around November 2019, we initiated a neonatal care unit. So what we did, at first we did facility assessment for readiness using our available resources. So we had some equipments like 1 radiant warmer, 2 concentrators, and other supplies which were available. But also we looked for available guideline and books for referring and some SOP. So we gathered all these, and thirdly, we committed staff. You can imagine how it was challenging in a facility where you have shortage of staff to commit 7 staffs just for NICU. So we had 6 nurses and 1 medical doctor for caring newborn in our facility. So we did mentorship for 1 week. So we consulted 1 expert who came in our facility for 1 week, and after that we continued managing our sick newborn. At first it was challenging. So in the first year when we started, we had a total admission of 713 neonates in our NICU. And you can see we had a total of prematurity were 143, and we had a total of 49 deaths. Out of them, neonates, preterm babies were 14. But we were not discouraged. Currently, this year, 2023, we have a total admission of 562 children, and neonates, preterm babies, were 117, and have only 12 deaths. So we moved from 49 to 12, and only 3 premature who died. So I encourage my colleague, DMOs, HMT, and CHMT to start. So if you see, just start, but know your limitation and do early referral. So RMO and the other RHMT for their support, and their team from who visited us, and they were encouraging us for improvement. And now we have given fund to renovate, to have a new or a nice and qualified newborn care with the capacity of more than 50 babies per day. So thank you very much.
Yeah, let me share a little bit on what we did as GIZ. We are working in this area on supporting newborn care units since 2015. We are starting in Lindi and Mtwara, then moving to Mbeya and Tanga, and are now focusing on Tanga region. And the number will be 38 newborn care units being established and functional, mainly in district hospitals, but also in regional hospitals and in some health centers. So how do we do it? It's like already Dr. Furaha says, you need to assess first and see what is there. You look for the rooms, do the renovations, procure the equipment, and then, and this is what I want to focus on more, you need the staff. So you have to do capacity building a lot. And what we also saw is that documentation and data is quite an issue, so we focused on that as well. And then there are other, not really minor, but smaller items like IPC, making sure the management is on board, organizing the ward well, and so many different things which really make life easier in such a unit if you care for them well. So let me focus on the capacity building. We all know that a NICU is not just the room, and not even just the room with these nice machines in it. It depends on the staff, and this staff needs to be trained. They need to be dedicated to their job and motivated on their job to do really a good work, because it's hard work working in a NICU. But we found that level of knowledge and skills in the beginning is really low. So you have to start kind of from scratch to teach each and everything. And we saw that mainly this can be done by mentorship. Only a training does not really do the trick. So we did a lot of mentorships, frequent mentorships, working with the people in their facilities to make sure really is their problem and where do we need to start and what do we need to teach them. And by this, we saw that really competence goes up, and providers themselves say we feel now more confident to do our work, and already this helps them to do it. Also, experience shows if you compare different facilities, we saw that those facilities who were able to really put staff in the newborn care unit and not share with the maternal ward as a general, they are doing much better. They have better outcomes of their newborns. And this is obvious because if you know somebody is working on both sides, newborn care and maternity, the mother in labor, she will shout and she has a voice and she will tell the nurse to come. But this baby who is taking the last breath won't say anything and nobody even realizes what's happening. So my second point is documentation and data. If a facility is not yet having any newborn care unit, it doesn't mean they don't have these sick babies. The babies are there, but we don't see them. And some of them might be treated, some of them get their antibiotics, but some are just lost and we don't know where they are and what is their outcome. And they will never go into any of our books, any HMIS tool, so we don't really know about them. So what we did is the introduction of the newborn triage checklist to make sure in the maternity wards these babies are checked and the sick ones are found out and taken to the newborn care units for treatment. And for the newborn care units, we try to make life a bit easier for them by developing tools. There is admission forms, there is observation charts and several tools which are now tailored to the needs in the NICU because you can't always use the same tools like used for the adults. Mentoring was done for documenting in the HMIS tools, and this showed in the beginning that the death rate goes up. Yeah. Now we see these babies. They were there before these deaths, but they were not seen. But after some time, you can also see that numbers go down when you do a good job. And at the same time, you see that numbers in general go up. Admission numbers definitely go up. Within 2-3 years, we saw double the number of admissions in those NICUs. But all these activities can't come alone. It needs the package to have a functional newborn care unit, and it needs the cooperation with the maternal care. A standalone NICU won't work. So we need to strengthen EMONC services as well, because quality newborn care, maternal care, starting from preconception until delivery, it has to go together. So let me wind up with some 5 recommendations we found from what we saw to make us run faster. The first one is this close link with the maternity. To avoid this, And we need specialization. For some nurses, they have to be really specialized in neonatal care so that they can improve the services in the NICU. And we need the separate NICU team, which is not working in labor at the same time. The third point is early detection of the small and sick newborns. It doesn't help to have a NICU if you don't see your patients and you don't admit them there. And we saw that improved documentation shows us the full potential. Yeah, we see now how many are there, how many sick babies, how many deaths, and this can only guide us in our planning. If we don't have this data, we don't know what we should do. And last not least, we should not only focus on these babies to survive, but we should make them thrive and reach their full potentials. And therefore, we need follow-up clinics. And we need to help them with their development and to support the families. Thank you very much.
Thank you so much, Monica. So we see we have the equipment, we have the people who are ready, we have the committed team. And the most important thing that we should know, you don't have to be on a clinical court, you don't have to be on the scrub to make an impact on the newborn care. And I'm happy to invite Doris Mollel, who is not, she doesn't have a medical background, but she's going to share with us the role of champions in improving newborn care in a country like Tanzania, briefly. Thank you.
Good morning. First of all, I will kindly ask you to stand up for 1 minute so that we remember all the children who were born too soon and have passed away with all this humanitarian crisis that we are seeing. We've been watching Al Jazeera and CNN, you see what's happening in Gaza, Palestine. There are so many premature babies who have passed away just because of what's happening. So for 1 minute, I'd like for you guys to pray just one word, and then I'll share with you everything that I would like to share. Thank you. Thank you, guys. You may sit down. Well, that's the role of a champion, right? An advocate. Well, thank you very much. For this most important day, I would prefer to stand up because for me this day is very important. And my sincere apologies, our moderator, I'll be mixing up my languages. So the role of advocacy and championing for premature babies, especially for my story, it has been 10 years of good hard work. It has been 8 years of being official, 2 years of just going around to understand what premature baby is and why is it happening in Tanzania, what's going on. So the late Dr. Agustin Masawe was my mentor, and I continue to remember him for that. Please clap a hand so that he can hear wherever he is. So he gave me the guidance of what you see today. All the advocacies that we have done through the Doris Mollel Foundation. So for my story, we started with raising awareness about premature babies. And then as we raise awareness, we tried to find, we came to understand that there's a very big burden and challenge on policies, and that's where the role of advocacy comes in to me, who have no medical background. But I'm lucky to have a mother who's a nurse, and I'm happy to be born in a family where there's nurses, doctors, and pharmacists. That's from my mom's side. I'm a pastoralist by nature. I'm a Maasai who, my dad has a background on so many pastoralistic life. So for them to have a premature baby is a curse. So I understand why I am here today. I'm grateful that God gave me life, and I'm really championing for it. We are happy that through Doris Mollel Foundation, we have been able to convince the government to budget for premature babies. And again, we've been able to support our government and championing it to see how best we can incorporate the knowledge into science and biology subjects. The best thing that I will leave for you today, I would say it's very expensive to do advocacy, and I would really wish if partners are hearing me here to invest on advocacy and policy change. There's so many things that we need to continue changing and amending in our government. I'm so delighted that our Excellency Dr. Samia Suluhu Hassan herself, last year in the World Prematurity Day, she donated 70 million Tanzanian shillings to support this day. And our Excellency Vice President, Dr. Philip Mpango, donated 20 million Tanzanian shillings to commemorate this day early this July. So what does this mean? They see this cause, and this cause has now taken a national attention. It is not easy. It's the role of all the people who have joined hands to support us. Today, let me sit. Today we have Jinako, we have Abby Chams, we have Barnaba, we have Alikiba, we have Mbwana Samata. All these are big names in our country, right? They're musicians. But we had to make them understand what is premature babies and what's the role of them as socialites, as influencers, as people who are being looked in the community. Again, we are expecting the 2nd of December to have a fashion show to raise awareness about premature babies. So all that ties along with what it means to raise awareness, what it means to penetrate in the government and the key policy leaders to help us change all what we're seeing today. So we're very happy that it's the work of Doris Moyle Foundation that today we see all these beautiful things that are happening on policy part. And we're very much thankful that we have been working very closely with the Ministry of Health that is supporting us in this day. Last one, today the Citizen has written that the World Prematurity Day now deserves a UN recognition. So it's a beautiful, good journey that we are starting, and we believe with all the beautiful voices we hear,
You have the wonderful panelists in front of you. I can ask questions, one from each zone. So if I can have one of the ushers, I can start with the zone just in front of me. If you have one question, please be brief. Newborns want us to be brief and direct, and ask your question, you can direct to any of the members. Going once, going twice, golden minute, going thrice. On the middle, if you have any question for the audience. Thank you so much. And thank you for the guest of honor who's just arrived. So, question for the audience on the middle zone. For the panelists, how can we move fast? 2.5. How can we invest? How can we make it happen? Yes, we have a question at the back. Thank you. Make it brief.
Thank you very much for giving me the chance to ask a questions. My questions go to Dr. Bundala and Monica, as well as Joe. Maybe you can comment on this. Of course, Monica, in her last statement, said early detections of newborn illness is very important. And as we can see, from the Tanzania Demographic and Health Survey, it tells us that the postnatal cares within 2 days is around 50%. Can you please comment on this? How soon should we see these newborns?
Thank you.
For early detections of illness?
Thank you so much. So the last question on the zone on my left. Question. Golden minute. Thank you. Mama. Hapo hapo. Uliposimama. Karibu. Make it brief. Golden minute.
Thank you. Jina langu Koleta Kibasa. I'm a pediatrician. We have heard a lot about what has been done in this area of newborn and prevention of newborn and premature baby mortality. Na naona vitu ambavyo ni vingi tunafanya ambavyo what we need labda ni kuangalia tufanye in a coordinated way kwa mpango unaoeleweka ili tuweze kufanikisha. Na tuweke target kwamba tumeonyeshwa DMO from Manyoni has shown us that we can run faster than the 2.5 times. So I don't see why we shouldn't start running. The ministry is doing a good job in building the NICUs, but we know that skills for healthcare providers, supplies and equipment are also required. So we can start making sure that we are running fast to achieve our goal. The second thing that I would like to talk about is about the graveyard that we have seen. We have been talking of graveyards of newborn babies, premature babies. but the equipment graveyard is pathetic. I know the issue of repair of medical equipment is a problem, not only in the area of pediatrics and in neonatology, but I think we need to have a system in place strong enough and make sure that these equipment are repaired on time. Apart from that, maybe it would be also good to coordinate with whoever is supporting. Sometimes these donations, people just donate whatever. So we should have a standard thing that if an equipment for this purpose is being donated, let it have this quality. Thank you.
Asante sana. So I'll now come back to the panelists. You have had the two questions. I think they were directed, one of them to Dr. Bundala. Yeah.
Thank you so much for the nice question. I'll try to be that much brief. Number one, it was about the detection during the postnatal. But what we are addressing basically is detection not only by waiting the postnatal, but even when the baby is still in the utero. The things we are doing in the antenatal clinic, in the labor and delivery to understand the newborns at risk to take actions, but also these service providers in the postnatal ward to do a thorough assessment and to identify who should be discharged home and who should receive the services in the different NICU premises, be it the kangaroo mother care or the general neonatal. That's why we are saying the competence-based training is going to help us much. Number two, from Dr. Kibasa, that we are doing a number of things, but what we are saying is that they're doing a number of things. Also have to make sure that we are doing it in a high concentration, the coverage. When you are saying in 2018 we had only 14 hospitals reporting to have the neonatal care units out of over 300 hospitals, that concentration is not enough. I think the science have shown below 80% coverage, you are less to get the expected impact. So we need to do things in a concentrated way, high coverage, in a consistent way, but also in a sustainable way. This is the move we have to go with. About the equipment, yes, it's not just the availability of the equipment, but the maintenance part of it. We all understand, we have been learning the shortage of biomedical engineers, but also even the involvement of these biomedical engineers. And as we are planning to establish this hub and spoke, we have decided not only calling or just sitting with the service providers, the technical people, to orient how to provide the technical inputs, but also involving the technical, the biomedical people, how to maintain the equipment in the same sessions. Thank you so much.
Thank you, Dr. Bundala. I would like just to add one sentence to this detection of the newborns. In our neonatal guideline, we have the newborn triage checklist, and I think that's a tool which can really help us. It just it helps us to check the baby 3 times within the 24 hours, the first 24 hours. And this is the time when 50% of the babies die. So of those who die, 50% of them would die within this 24 hours. So if we use that tool, I think we are already quite far. We would not have detected all of them, but quite many.
Thank you. Joyland, the last comment?
Chair, can I add after Joy?
Sure.
Thank you for the question. And I think the thing that we sometimes forget is a baby dies in minutes. So if you're waiting to the next day, it's too late. So there's nothing that marks the strength of your health system more than whether it can manage a small baby, especially a preterm baby. Otherwise, we said 50,000 Tanzanian newborns dying each year. And just like you said, you have to start even before delivery. This is important. For the equipment, you also have to start before you place it on the ward, because if you get the wrong equipment or you don't have people there to look after it, it won't work. And I just want to take this moment to salute Tanzania. You have made remarkable progress for Mkutano. You were one of the only African countries to meet the Millennium Development Goal for child, and that was particularly under the leadership of His Excellency President Kikwete. And I long to come back in 2030 and see that you have run 2.5 times as fast, and you've also met the goal for the newborn. Thank you.
Yes, thank you, everyone. Just to add to Dr. Mrisho's question and response, that together we are also learning, as I presented, with a combined approach, care of mothers and babies for national equity. Moving forward, we are learning in Mwanza region, and we are setting a feasibility study to see how best we can structure the post-discharge follow-up. So using a risk stratification and stratifying the baby according to the risk score, and classify as either high risk, moderate, or low, and then see which level of care and follow-up, intensive follow-up or basic follow-ups, will be tailored to that baby, either face-to-face or teleconsultations, so that we prioritize for those who need care, not miss, and they get the right follow-up and the right directions following our Road to Health guidelines and policies, which incorporate already the growth and development of these babies.
Thank you so much, Dr. Nahia. And a round of applause to the panelists. So I'll now ask you to stand, and as you're standing, Dr. Teo, please unveil whatever that is on the box and put it on the table next to you. And the rest of the panelists, you can step down towards my left. You can go there. You can go down to the stage. Teo. And thank you, Dastan Bishanga, for the wonderful opportunity, and I now submit. Thank you.
Another round of applause to the panel. I think you confirmed my pledge that this was to be one of the best sessions at this conference. Makofi tafadhali. So, ushers, naomba huku juu, naomba tutoe viti, tubakize viti 5 hapa. Ushers ya lakalaka, naomba tukimbie. Naomba vishushio upande huo, vikawekwe kule. We remain with the 5 seats. Mnaziacha. Charity